patient. And we will now move on to the last talk for the day by Professor Vinita Gupta. She is from AIMS Rishikesh. She also does a lot of work on glaucoma and a lot of other miscellaneous activities in ophthalmology. I hope you are participating in the cultural program in the KSOS. Choosing an IOL for a child, it's not a child play.
I thank KSOS and Dr. Bastian for inviting me here. So my talk will be on choosing an IOL for a child. It's not as easy as a child's play. We know there are lots of developments and advancements in technology has already been shown by the improvement in the IOL formulas for the adult eyes, but the field of pediatric cataract surgery is still lagging behind regarding that. And why do we say the IOL power calculation in a child is different? Because we're trying to choose an optimal IOL power for an eye that best befits a small eye. It's an eye which is not actually a miniature eye, but it's an eye which is a growing eye. So we are implanting a fixed IOL power in an eye which is still growing. The younger the child, the more difficult is the problem. And we are using formulas which have been designed for adult eyes. We do not have any formulas designed specifically for those growing eyes. And then we have the measurement issues, which are the various concerns of measuring the mean keratometry in the axillary length, the main parameters for your biometry, the various materials and the choice of the IOL, what should be the IOL best, which is suited for these children. The calculation formulas I've already talked about, and what is the target refraction which we are aiming at? That's another big issue. And then the long-term issues of the myopic shift, which is happening in these children as they are growing, and the visual axis opacification. So if you see by this graph out here, you can see the normal eye growth is occurring at birth. The axillary length is around 17 millimeters, and there's a rapid growth in the axillary occurring during the first 3 months. Similarly, at birth, the mean keratometry is around 51 diopters, and the rapid increase and stabilization to the adult values occurs by the first 18 months of life. Similar is for the lens power. For the first year, it is a dramatic decrease of almost 10 diopters in the power of the lens, or the natural crystalline lens. So if you look at this figure, and as I shown in the previous graph, the maximum myopic shifting is occurring during the first 2 to 3 years of life. Besides this normal eye growth, the other factors which affect your myopic shift in a child is the laterality of the cataract, whether it is a unilateral or bilateral cataract. What is the time when we are operating this child, whether we are leaving a child aphakic or we are implanting an IOL, and obviously the genetics of the child, depending on whether his parents are myopic or not. So remember, as I said earlier, this is not in a miniature eye. The pediatric eyes are not miniature eyes. They have a different anatomy altogether. They have a shorter axillary length, but at the same time, they have a steeper cornea with very high keratometry readings and a smaller anterior chamber depth. So the standard IOL power formulas which are using for the adult eyes are inadequate for them, because most of these measurements are being done by the ultrasonic biometers. So obviously the velocity of the ultrasound through the different structures will vary in these. Then the measurement issues, as I said earlier, we have most of the children, especially less than 2 years, 3 years, it's very difficult in the office settings. Most of the time we have to take them to the general anesthesia and do measurements there. And this also leads to errors in measurements because we are not coaxial exactly in when you are doing measurements under GA. Then second issue is the lower ocular rigidity. So obviously when we are doing maybe doing an immersion biometry, applanation tonometry is one what we are doing. Applanation contact ultrasound is what we are resorting to most of the times, because they may not allow, especially when we are doing it under not without anesthesia. So they will be compressing on the eye when we are doing an applanation or a contact ultrasound. And those cases, obviously, there is low ocular rigidity in these cases, and hence there is more impact of compression. For an adult eye, if it is about 2.5 diopters per millimeter of compression, it is about 3.75 diopters for a child's eye because of lower ocular rigidity. And if you're going under anesthesia and we're trying to measure these using a handheld keratometers for the keratometry readings, obviously we are not coaxial. So obviously this leads to inaccurate keratometry readings, and also the cylindrical values of the, especially if there's a high astigmatism, they're not very accurate for your using the handheld autokeratometers. Also, every center may not have handheld keratometers. Infants, also remember, this has been seen in certain studies that girls tend to have, girls tend to have a steeper corneas. And also in the bilateral cataracts, the keratometries are steeper as compared to the unilateral cataracts. Then we have the issues related to measurements of the axillary length. Obviously, as I've already discussed, immersion would be the preferred technique. But again, when we are doing it whether in the not in the awake position in an awake child, or whether in anesthesias, we are not exactly perpendicular, because it's very difficult to instruct a child to look directly into your light of the ultrasound probe. So best is to measure in the calf, use the calf method, which is to measure in the aphakic mode and add 0.32 millimeter to that, because this is averaging out the velocity of the ultrasound when we are doing and taking care of the rest of the structures which have different dimensions. Optical biometry obviously would be preferred, but it can be done only in older children. And the effect of cycloplegia also is important, and it's important that even for the adult eye we say that, but for children it's much more important that do not dilate before you do these measurements. And then with IOL power calculation issues, since these IOLs which are required for these children are much higher powers, hence more exact axial positioning is required for these. Because of the various issues which I mentioned earlier, shallower ACDs, greater vitreous pressure, steeper corneas, and obviously the capsular contraction syndrome, which is quite common in these eyes, the results of the axial positioning or the exact positioning of IOLs is much less predictable in these cases. Any of these formulas do not work for pediatric IOL calculations, and more is the variability, lesser is the age. The desired, obviously as a pediatric ophthalmologist, my desired aim is to hit the target. Generally we undercorrect. Higher the IOL power, greater would be the undercorrection. For bilateral cataracts, I would go for greater hyperopia. For unilaterals, because of the risk of amblyopia, I do not want much of an anisometropia, so I will aim for a lesser hyperopia. If there's a dense amblyopia, again I will aim for a lesser hyperopia. If there's a poor compliance, again I'll aim for a lesser hyperopia. And if the other eye is a unilateral cataract, the other eye has a significant refractive error, I will aim it closer to the refractive error of the other eye. So this is the general dictum which I use in my practice. For unilateral cataracts, I usually aim for the spherical equivalent for children less than 4 years, minus around 1.25 diopters. But if it is more than 4 years of child, I usually make it equal to the spherical equivalent of fellow eye. For infants, the infant aphakia treatment study obviously was asking the infant to be left aphakic, but nowadays the trend is towards implanting an IOL, even at the age of 3 months of age. So for less than 6 months, usually leave a moderate hyperopia of around 3 to 7 diopters. For more than that, it is usually around 3 diopters, 1 to 3 diopters, depending upon the other eye status, or whether it is a bilateral cataract, around 3 diopters. Then we have a pediatric IOL calculator also available to predict the future growth of the child, which is available in the SKRS site. These are the general undercorrection guidelines I follow in my practice now. For less than 2 years, obviously there's more spurt of growth. So obviously earlier Dahan said all 20% for all children less than 2 years, but now we vary it for the age according to the age of the child. And for more than 2 years, it is reduced 1% per year of age. And the best choice for is the primary IOL placement and doing an optic capture, which could be in the bag or behind the posterior axis, or doing a primary piggybagging, which is you place one IOL in the posterior chamber and one in the sulcus, and or change the power of the sulcus IOL at the times as a child's eye grow. Best would be an hydrophobic IOL in the in the bag. Multifocal IOLs and the toric IOLs obviously can be our preferred modality if unilateral cataracts, if there is a significant post-traumatic cataract with significant corneal perforation which is repaired. And for secondary IOLs, again remember, you are usually not able to place in the bag. Usually they are placed in the sulcus or the anterior chamber because the capsule has contracted and you're not able to usually separate them when you're operating at a later age. Hence, when you're doing the measurements of the secondary IOL calculation, again we have IOL calculators for that. But remember, these patients may have been on RGPs. So please take your measurements after removing the RBGs, such as the last slide. And whatever is the type of IOL which you will be using for these could be a scleral fixated, the iris fixated, the retro-iris fixation lenses are also available nowadays. And for secondary the scleral fixations, I have started using it in children after the age of 5 years. It works well, especially using the Yamanese technique. And piggybagging can be done for the secondary IOLs as well. And so to summarize, I will just say, customize for each eye according to the age, the laterality, the visual potential, the visual amblyopia status, the likely compliance with the contact lenses if you're not, if you're leaving the child aphakic in the primary setting, family history of myopia, and whether you're placing the IOL in the bag or in the sulcus or in the anterior chamber. So in the end, just to summarize, I would say careful consideration to the growing parameters of this child is very important to make the child as emotropic as possible when they are growing, when they actually reach their adulthood. Thank you.
Thanks a lot, Dr. Vinita. It was really a very